Welcome back to the Zac Clark Show. I am very excited about today's guest. Dr. Cara Poland does it all, apparently, but she has really left her mark in the behavioral health care field. She is a board-certified addiction medicine specialist. She's a faculty at Michigan State, which we were just talking about. She's trained over 1,000 physicians through MI Cares or Michigan Care. Is it the MI's for Michigan?
Yes.
Yeah. And she's doing unbelievable, groundbreaking work supporting pregnant individuals with substance use disorders. And I want to welcome, first of all.
Thank you. It's great to be here.
How are you?
Good. Thank you. How about you?
You flew in for us, which I appreciate.
Absolutely.
And I have permission to call you Cara.
Yes.
Okay. I want to start. So when I read board certified addiction medicine, I've been doing this for, I just shared 13 years working in behavioral health care. And there's a push right now around the language, right? So this word addiction, substance, how important is it? How important is the language? Does it matter? Does it not matter? I go both ways, and I'm just curious.
Yeah. I think the words we use matter, right? And so when we're talking to somebody who has a substance use disorder, what we know is that if I call them an addict, they feel stigmatized. But they might use the word addict. And even if they say addict, they still don't want me to say addict back to them, which is fascinating, right? So the way somebody self-identifies isn't necessarily how they want us to identify them as a provider. We also know that if we use the words substance abuse, which were old diagnostic terms that haven't existed in over a decade, but still kind of come out from physicians and from other healthcare providers, that the public, so that loved one that might be with the patient, that the image that we have out in the community is that people believe that they're less worthy of treatment, less deserving of treatment, more likely to benefit from punishment. And we know that the opposite of addiction isn't punishment. The way to treat addiction is with kindness, compassion, and surrounding that person with support. And that's when we see recovery happen. So I think that the words we use matter from that standpoint in terms of how the public perceives us, but they also matter in terms of how we communicate within medicine. So we also know that if we give doctors two kind of written case studies about patients and they're the exact same, except in one case we say substance abuse, and in the other case we say it's a person with a substance use disorder, that we provide higher quality care to that person with a substance use disorder. That's what we call implicit bias, right? That's what we call kind of unconscious bias. We don't know that we are doing it to our patients because all we did was change the type of disease, the name of the disease that the person had.
Yeah. It's very interesting to me because my personal story, right? Like I went to treatment for 4.5 months. I was an IV heroin user. I got out of treatment. The program I went to was very 12-step based. I did use medication assisted treatment by way of, Suboxone to kind of get detox, and I was discharged on Vivitrol, which are medications if you don't know and you're listening. And I found my way through a fellowship. I'll leave it there. And I think when I engage folks, they assume that I am going to force that one way onto them, and that's the only way. And I know that's not true. And I think for me, as someone who's watching your work and watching the work of so many smart people out there, it's always interesting to me when I see, on the internet or wherever it is, like the harm reduction communities fighting with the 12-step community, which is fighting with the evidence-based, like these communities are so prideful, but like we can all work together.
Oh, I absolutely agree. I think it's a continuum. I'm actually writing an article on that premise with a colleague of mine who's a ethicist. So this is like a key thing that I've been thinking about. It's not either or. Harm reduction is an important part of a lot of medicine that we do. So if somebody has diabetes, and their blood sugar's out of control, I don't remove their insulin. I don't not let them see the physician. I don't tell them that they're bad people and therefore, come back in 6 months when you're ready for treatment for your diabetes. I try to engage them where they are and try to see what we can do to reduce the harms. I'm not going to send them to the eye doctor, or the podiatrist, or any of the ancillary services that they might need, which are actually a direct consequence of their uncontrolled diabetes. right? And when I send them to the eye doctor or send them to the podiatrist, they're not going to say, well, because you're here with it from the diabetes, we're going to, tell you you're a bad person and you should really take better care of your diabetes. No, they're going to treat that patient with kindness and compassion and address their other issue that is a consequence of their diabetes. But we don't do that in addiction. And I think a lot of that is a result of the fact that we were founded as a nation by a Puritan group. And so there's this like value and judgment that we give to substances. But what we fail to remember is that we all fall prey to that. There is only one pleasure reward center. It is the same center in all of us. And so if I use a simple sugar, why is it easier to say yes to a donut than it is to say yes to a bowl of broccoli?
Right.
It's the same kind of idea, but I really think that this is a continuum, right? We want to keep people alive by providing them with harm reduction resources, but the harm reduction services, in my personal opinion, should be well trained in basic counseling techniques like motivational interviewing to help try to work that person through stages of change into treatment.
Yeah, I mean, I never thought of it this way, and you're blowing my mind right now, because so in the 6 months before I went to treatment, I was doing kind of like the daddy home rehab thing, where my dad was kind of doling out my Suboxone, and you were getting $20 a day, and like he was putting these things in place that, quite frankly, now that I think about it, like it was a little bit of harm reduction. Like he was just waiting for that moment, which ultimately came, and he's not a trained physician. He was a businessman, but it worked, and it kept me alive. And then one day I was able to kind of like see the light or have that moment of clarity where I was like, okay, I'm ready to really look at this thing.
Right. And we have to capture people when they're in that moment, because that moment can sometimes be fleeting, because these substances have such a powerful hold on the thinking processes within our brain. So when somebody is ready for treatment, we need to meet them in that moment.
You talk to my team. I am the sense of urgency. Like when someone calls for help and I'm like, do not let them hang up. Like let's get in the car, and we mobilize. That's what I've built really a career on, just answering the bell, because I know if we don't get them in that hour, in the next couple hours, they might find a way to get high one more time, which could lead to 1,000 more times,
or in worst case,
right,
that last high leads to their untimely death.
Yeah.
Dr. Poland, can you just frame, because Zach mentioned some stuff, but you do a lot of different things at the local, state, and even national. Can you just sort of frame like all the work that you're doing so that people really understand like you're involved and aware of a lot of different things happening in this space?
So I like to kind of bucket my work into a few different buckets. I have a clinic where I treat pregnant and parenting women as well as other folks with substance use disorders, that really focuses on how do we support that whole unit. We think of it as a family unit rather than just the pregnant and parenting people, because we all know that if you are in a relationship or you are living in a home with a parent or with a sibling or with anyone else who is using, trying to stay on the road of recovery is going to be that much harder. So we want to treat the support people around that pregnant and parenting person. I also run what we call a fellowship, which trains addiction specialty physicians that will be kind of the future workforce, and they rotate through
One
that
of your students
clinic.
is in the house today, right?
That's true. One of
Shout
my lab students, Madison Walsh, is here with
What's
us
up,
today.
Madison?
I'm good. Happy to be here.
So I have students, everything from medical students, so future physicians, to currently practicing residents, as well as fellows, and then Madison's an epidemiology student. So I get students from all over. So that leads me to kind of the next bucket, which is education. And the Michigan Cares program was started to really focus on ensuring that there were addiction specialty physicians at each of the medical schools in Michigan, so that we could train the future medical students, because if you don't have the faculty member to train them in a kind, destigmatized, understanding manner of the principles of addiction, then you're not going to graduate doctors that are capable and competent. At the time in 2018, when we were founded, the average practicing physician had 10 hours of training in addiction across the about 10 years it takes to become a physician. So it was dismal, right? Like, how can you know what to do? Just think about what the outcry would be if that's the amount of education and training that somebody had to treat high blood pressure or asthma. We wouldn't graduate those students. So we started this program through a collaboration with the Michigan Department of Health and Human Services, trained the 6 docs. But as happens in, I think, all fields, I'm sitting in my clinic and I've got my colleague sitting next to me and I'm getting special help to become boarded in addiction. My colleague wants that. So we went back to the state and said, hey, can we expand our purview and train other doctors? And they said yes. And then we got a call from somebody in Ohio. And I don't know if you know much about Michigan versus Ohio, but I went back to the department and said, I know it's Ohio, but could we help this doc, because Ohio also needs help. To date now, we've had over 18,000 people enroll in our program to get education and training on addiction. So it's pretty remarkable.
I mean, it struck me when you walked in with like, I thought it was just going to be you and literally one of your lab students. So it's powerful. That was powerful. Just that was enough for me. I was like, she's doing it.
Thank you. No, it's about also inspiring the next generation. So when you have opportunities to show them what their future could look like, why you do sort of the advocacy and the public facing work, which is kind of my third bucket. I think it's important for them to get that exposure, to be able to see what that looks like so that they can understand that, well, I can be a doc in an office treating patients, and that's really important work on the one-to-one basis, but that there are these bigger, broader things that you can do depending on where your interests fall and your interests lie. So that last bucket is advocacy. I'm the current chair of the Public Policy Committee for the American Society of Addiction Medicine, so I sort of lead the writing of the policy for the nation.
Can you say that again? Because you like went way so fast through that, and that's
sorry.
like huge. No, I mean, no, that's huge. I just want people to really hear that.
So I'm the chair I just was trying to give a pause so that their cutting time would be easy, and I was flubbing over my words.
Hear that again. It's impressive.
So in my role in advocacy, I chair the Public Policy Committee for the American Society of Addiction Medicine, which is our largest physician-run organization in the United States. And so what I do in that role is I direct and lead the writing of public policy for the nation. And then those documents are kind of the documents that people can take to their local legislators, our federal legislators, or even just their clinic manager and say, hey, we should probably think about doing this or doing that, or, there's policy around how we could best support people in this space. And so that work to me is kind of that global big picture impact. At a state level, there's something called the opioid settlements, which has been a national effort to hold accountable pharmaceutical manufacturers, distributors, and developers of opioids. Michigan is slated to receive about $1.6 billion over the 15 years, and half of that goes directly to the counties, townships, and municipalities, and half of it goes to the state. And I chair the legislative commission, so it's in a nonpartisan portion of our legislature that advises the legislature on the appropriation of those dollars.
So you're helping steward those funds, or
yeah,
amazing.
So I'm kind of making the recommendations to the legislature on how those funds can and should be used, while also really encouraging Michigan to up their game in terms of transparency and accountability on how they're using those funds, because this is a once in a lifetime opportunity to create infrastructure that will hopefully save lives, not only in this current epidemic, but if we have the infrastructure then as things evolve, because drugs evolve, right? We all know this. That's what's happened for thousands of years, right?
Yeah.
So how can we make sure that there's some infrastructure built that can help us continue to address substance use longer term?
Yeah, I mean, I remember, we're coming to like a gunfight with a knife to a certain degree. Like I even share that, when I was in hospitals during my use, and even now when I like go into a hospital to speak, like typically they're sticking those people, the behavioral health care, like in the basement like away from everyone else, and the facilities are not, and that's not how we're going to cure this thing. So if we have the resources and they can be pointed in the right direction, that would be beautiful music to my ears.
We've spoke to Doug. Have you ever done, I've being sober and through 12-step programs have, gone into hospitals and told my story and basically had a 12-step meeting in there with doctors watching as part of a program, like, med students. And, just shocked at how little they understood about addiction, which is qualified as a disease. I mean, that's not debatable, is it?
It's not really debatable. Addiction is what we consider a chronic disease. When they've looked at kind of relapse rates in addiction and compared them to diabetes and hypertension, they're not different. So we don't talk about hypertension in terms of, oh, this person relapsed from their hypertension. We don't talk about diabetes in the same way. And, really working toward changing that language is really important because none of us are perfect, right? I always tell people, if I go on the no chocolate cake diet, what's the one thing I'm going to want more than anything else in the world? Chocolate cake, right? And if you have a birthday party and you have a chocolate cake and you don't know that I've been on the no chocolate cake diet for the last 18 months, and you know that chocolate cake is kind of something that I really enjoyed or used in the past, you might offer it to me. And it's going to be that much harder for me to say no to my friend who's offering me this piece of chocolate cake out of the goodness of their heart, right? Than it is, to say no to something else, right? And so we kind of punish people in a way and have these very judgmental methods of treating them and talking to them that we don't use in other areas of medicine. Look, we know that the weekend after Thanksgiving, like the Friday, Saturday after Thanksgiving, there are higher rates of things that are consequences of diabetes in the hospital because people are relapsing from their diabetes on Thanksgiving Day.
Yeah, that's so interesting. Everyone needs to hear that. You've talked a lot about the training that you've done and the lives that you've impacted. Your journey started with a very personal connection. My journey in behavioral healthcare started with my own recovery. Can you talk a little bit about your inspiration, which you've shared very openly about your brother, and how you've used that tragic loss to fuel your career and really be such an amazing inspiration to all of us?
I think my personal journey keeps me grounded. I think I've heard that from you as well, that, the why becomes very apparent when you have a very personal connection to a subject. And so for me, that connection is my younger brother. So when I was in my training, I was in my fellowship, kind of the final stages of addiction training. I was really close with my brother, and we had planned on him coming to celebrate the winter holidays with Christmas coming up with my family. I had a 10-month-old baby at the time. And so I had invited my brother to come to Boston where we lived, bought him a plane ticket, and he didn't arrive for the holiday. We ended up calling for a safety check, and the police went to his home. And a few hours later, I got the phone call that he had died of a self-inflicted gunshot wound related to kind of his depression and his opioid use disorder. Oh, no, he had alcohol use disorder. Let's try that again. I don't know how that came out.
You needed to laugh in that moment.
It's good we can laugh, seriously.
Yeah.
I don't even know how that came out.
We're not taking any of that out.
We usually should be in the bloopers. It should be like in the bloopers for sure. Should I start at the beginning?
No, wherever you are.
You're good. He had an alcohol use disorder, yes.
Yes. So he died of a self-inflicted gunshot wound related to his depression and his alcohol use disorder. And he'd been in and out of treatment. I was well aware of the medications that could support him. He was in law school. He had what from the outside looks like a pretty bright future. And I think that's something that happens, right? We never know what's going to flip the switch. And, talking to him prior to his death, I learned that he started drinking when he was about 14 years old, which is not uncommon. Right. The average age of first use is between 11 and 13 years old. So it's, he was right in that space. And we know that when people are exposed at younger ages, they're more likely to develop a lifetime substance use disorder, which is why we always in the prevention world are trying to delay onset if we can. And so that kind of became the fire, right? The why. And after my training, when I moved to Michigan, I learned that in Michigan, there was no way for a physician to get reimbursed for an office visit to see a person with a substance use disorder. And when the billing people at the organization, told me that, I frankly thought they were wrong, because there is from 2008, the Mental Health Parity and Addiction Equity Act at a federal level. And I was like, well, this is clearly a violation of that. So how can you do this? And it was kind of a game of he said, she said, where in Michigan, we have what they call a behavioral health carve out. So that is the carve out, they carve out the services for Medicaid recipients. And then we have kind of the rest of their health is through a more traditional HMO process. And both of those entities said it was the other person's responsibility. And it took 7 years. And that's really how I got involved in advocacy, is I just didn't stop talking about it. And what I kept saying is, like, every day I wake up and there's a picture of my little brother in the bathroom where I get ready for work, right? Where I get dressed, where I, brush my teeth. So I see him when I wake up and before I go to bed every single day. And that is my reminder that we fight for the right thing, for the right people, for the right reasons. And if I don't know, I have a moral, ethical responsibility to say, I don't know. I will try to figure that out for you, but I don't have that information. But for 7 years, I would walk into these rooms, and I still say it today. And, I will always wonder if Max had been offered medications to treat his alcohol use disorder by a physician, if he'd be alive today.
Yeah, I mean, it's tragic. And I think anytime we lose someone, I've, clearly experienced a lot of loss and just doing this work, as I'm sure you have after Max, and I want to hug you, but we're sitting here. We always ask ourselves those questions. We always ask ourselves, and we've had grief experts on, and it's just, I don't know. But to your point, like, I don't have the answers, and
right. But how can we all work together to create a safer, healthier community so that other people don't have to suffer either, a death like my brother's, but also just the devastation of those lost years to a substance use disorder, whether that's a person's own or somebody else's. One thing that I think is really cool about recovery is, for me, I think when I see my friends, my patients, the people that I know in recovery, I think they're like better, awesome, fitter, more amazing people because they had a substance use disorder. Not to say that I wish a substance use disorder on anyone, but the outcome of somebody who's successfully been in treatment is often so cool, because there's this new passion, drive, and license on life that I don't know would have existed without that deep experience.
Yeah, I mean, I feel very fortunate where I
100%.
Dating, and people worry about dating in early recovery. They worry about how you're going to tell your friends, how you're going to tell your family. And for me, I was just very straightforward, because I don't know why I kind of had this willingness, and maybe it's how God is choosing to use me, but I would just tell people. Mm-hmm. And no one ever judged me. And if they did, it was, outside of that conversation, and maybe
right.
They ran back to a friend or someone like, did you know about Zach? And the more I did that, the more people were like, that's really cool. Tell me about that. That. So it's like this energy that we bring to it. I'm like, and that's why I asked the question about language, because I am a drug addict. Absolutely. I love drugs. I love alcohol. Typically when I do a lot of drugs and alcohol, I get very anxious. I get very depressed, and I start to question my existence, and that's facts about my life. Having had that experience, I am full of joy and happiness, and my life is so big and beautiful today, and I know that's because I'm a drug addict, to your point.
So I'm just a lot of thoughts, but why? I guess my first thing is, it's everything you're saying. It sounds like it's a fight, right? It's just like a fight to make people at a governmental or policy level recognize and understand, like, why is it because this isn't like a natural disorder, or is it because there's just the stigma of, well, it must be a moral issue? I mean, like why isn't it just recognized in the same lens as hypertension, diabetes, these kind of other chronic issues?
I think a huge part of it is judgment, stigma, and lack of understanding. We spend, as a physician, between medical school, 4 years, residency 3 to as many as 10 years. So we spend on average 16,000 hours in training. And remember, only 10 hours of that have historically been in addiction. Just think about that for a minute. That's impossible. And that's what the healthcare system is doing, right? That's what we're doing to train your doctors. No, we translate that to our government officials. We translate that to people on the Hill, and they only know what they've heard, what they've seen. I have a good colleague named Jonathan Stoltman who runs a program called Reporting on Addiction, where he works to train reporters on how to write these stories to be more humanistic, kind, compassionate. And he encourages them, and as part of this training, to look at their own biases and examine where they might be coming from so that they can understand where those exist, so that they can maybe avoid them, bring them to light, so that it doesn't end up infiltrating, for lack of a better word, into their reporting, which is really cool, right? And so we do some of those types of trainings in the My Cares program with medical students. So how does your personal bias, what baggage do you walk into the room? And when I talk to residents, I will often ask them, if you have 2 patients, one with diabetes who appears uncontrolled and one whose diabetes appears under good control, which room do you, as the physician, have to take the deep breath before walking into? Right? It's harder for us. We feel less effective when we're walking to a room with somebody who has an uncontrolled disease state. And what tends to happen in addiction is that a lot of times physicians, other healthcare people have only kind of seen visibly uncontrolled addiction. And so they haven't seen the people like Zac that are in recovery, because there's so much stigma that not everybody is as brave as Zac is to be able to say, hey, I'm loud and proud and in recovery, and that's a part of my healthcare, and you need to be aware of it. Because there's this fear, or there's this idea that maybe it isn't part of their healthcare. Because we've had I joke around that the neurologists have taken over the brain, so I'm in the ether in addiction. In some people's minds, right? Like I'm like the aura around the person, which is kind of how a lot of people look at addiction in the healthcare systems. And we've got to break that down. And to me, that's why I do the education stuff, because I want to prevent them from developing that judgment, prevent them from becoming stigmatizing when they go in there. And if the only thing that is a positive outcome from that training is that when they walk into that clinical situation and they hear somebody say substance abuse, they think in their head, oh, that's not what Dr. Poland said. Dr. Poland said that we should be using these other words. Then I feel like that's a win, because we also know that if we use the word substance use disorder, we unconsciously provide better care. So look, we're changing the healthcare system just using the words that we say.
I love that. I do think the language is important. And I like I said, I've gone both ways with it. And this thing is so insidious. I mean, so as a business owner, you talk about stigma. I have 2 recent examples that I want to share with you, because I feel like we're on the same page. One is we went out and tried to get a line of credit with a bank or a business, and they came back. Oh no, we wanted to accept ACH payments, so we had to go through this process to be able to receive money in a certain way. And they said, sorry, we can't do that for you because your payers are unreliable, right? Our payers, our patients, our clients are unreliable. And I said to them, are you looking at our books? Like
Right.
for 8 years, we've been a very good customer of this major bank. We've never been late with anything. We've never overdrawn a account. We've always run a business, and our payments always come on time. And I got very animated, and I tried to educate the person, and it just wasn't going anywhere. We ended up going to another bank because it was just so frustrating. And then the second part is we're up for our insurance renewals, and we employ about 100 people here. Mm-hmm. And a lot of us are in recovery, myself included. I've probably used my insurance 3 times in my recovery. Like literally, I go to the doctor, whatever. And again, sorry, we need to like jack your rates up because of the types of people that you have working for you. And I'm just like, and I sit there and I'm like, am I fighting this fight or not?
Right. Well, I have 2 sticky notes that are on my monitor at home. One says, keep the passion, control the emotion. And there are definitely moments that I'm walking into that room with that senator or walking into that room with that, executive at my organization or at a local organization. And I am thinking in my head, keep the passion, control the emotion so that we can have a fruitful conversation. And then the other one says transformative change was never brought about by reasonable people. So it's a kind of a balance.
Both of those are like hit me right, like right here.
You need the sticky notes.
Yes.
You need the sticky notes. It's a great way to remind myself of kind of what those values are, right? And what is the North Star in terms of this work and the broader communities that we're serving.
Yeah. Where do you want to go? Pregnant? Or you?
Yeah,
you
how did you get there? I mean, we have a stat that blows our mind in terms of
10% of all pregnant use illicit substances. So if I walk down the street and I see 10 pregnant women, one of those, please.
And that's illicit substances, right? So if 1 in 10 people use an illicit substance during pregnancy, that does not include alcohol. Wow. Right? So just think about what those numbers actually are and the lack of compassionate care that these folks can find that lead to them hiding their use, not telling people about their use, all of those things, which are so unfortunate when we look at the broader amount of care. What I love about treating pregnant people is I have yet to meet a pregnant person that doesn't do something during their pregnancy in terms of their own health care in order to improve the outcomes for that baby. I'll give you myself as an example. I have 2 children. I had fertility issues, so I spent 2 years trying to get pregnant. Then I got pregnant. Then I was breastfeeding. Then I got pregnant again, and then I was breastfeeding. So it was like 6 years of getting pregnant, pregnancy, breastfeeding. And I am one of those terrible, awful, evil women that is an overproducer of breast milk. So I had like gallons of breast milk in my freezer. I know. Everybody throw the eggs.
Yeah.
Well, maybe not eggs because that might be kind of expensive right now. But I'll address the hate mail when it comes. So on my daughter turned 1, and according to the American Academy of Pediatrics, you're supposed to breastfeed for 1 year. Her birthday is February 1st. We had a birthday party on February 15th for her. And the morning of the birthday party, when we're, putting everything together, getting the house ready, I looked at my husband and I said, I'm going to McDonald's. And he was like, what are you going to McDonald's for? Do share. And I said, I am going to McDonald's to get a Diet Coke because I have been 6 years without a Diet Coke. And she is kind of weaning from breast milk. There is plenty in the freezer. And I'm done breastfeeding and I want my body back. Right. And, but I went out and got like the gold standard of Diet Coke. If anyone else is kind of a Coke product drinker,
the Diet Coke
aficionado,
McDonald's is elite. It's elite.
It's the best, right? There's like there's a whole theory behind it that I have. But
what
anyway, okay. So there are 5 things with Diet Coke that from McDonald's that make it the best. They actually have a different ratio of syrup to carbonated water that they use at McDonald's so that the flavor doesn't dilute as much as at other places. They require the syrup to be climate controlled during transportation. And it's transported in stainless steel instead of in plastic. And so when they infuse it together, because the stores are required to keep the syrup at that same temperature. Most places it's kept at room temperature. So the coldness, it comes from the carbonated water, but at McDonald's, it's actually the same. And then the final thing, which I think they've messed up recently, is the straws are like a broader diameter, and that allows more bubbles to get in your mouth and burst in your mouth instead of in the straw.
We have a shake shop on this block, 19th Street in Manhattan. They have these straws that are like, I swear, you're drinking the whole beverage in one kind of like suck, and it's like my favorite thing in the world. But I digress.
There's like a whole thing. But anyway, like
I'll send you some. I'll barter for some of these straws and send you a couple.
Yes, it's amazing, right? When we think about it, like there I was, the pregnant and parenting person who was like, all I want is a Diet Coke, right? And it was like perseverative at times where I was like, I just really miss Diet Coke, or I'd see somebody drinking a Diet Coke and I'd be like.
And really what's your fear in those 6 years of having one Diet Coke?
Probably an unfounded fear that it was going to cause, my child to spontaneously combust or something completely irrational. But it was like...
If you were treating you as a doctor, would you say, have a Diet Coke?
I would have totally said, have a Diet Coke. And I also would have said, like... your child is not going to be harmed if you have a Diet Coke, but also your child is not going to be harmed if you are so nervous about having a Diet Coke that you want all the Diet Coke and the caffeine and whatever chemicals out of your system, and you decide you don't want to breastfeed for 24 hours after you have said Diet Coke, if you give your child formula. Right. So I was putting all of this on myself, right? And all this weight and all this pressure, and pregnant people do that. A lot of pregnant people do that. It's not like unique to me. It's not unique to the disease of addiction. So when I talk to people, I say, just like I didn't drink Diet Coke when I was pregnant and breastfeeding and trying to conceive, my patients are just trying not to use fentanyl or alcohol or whatever the substance is. It's
but
the same thing.
You don't have a substance use disorder, right?
I don't have a substance use disorder.
Okay, so and I think that's where a lot of the stigma comes from, which is, unless you've experienced it or seen it a lot like you have in your work, it's very hard to understand what is actually happening, right? And it's this mind-body kind of thing, right? And the body, the mind is like has this ability, like a sane decision versus an insane decision. And I remember, and I've spoken to so many people, like 2, 3, 4 days, okay, I'm living healthy. You get to that moment where you open the fridge and you see the thing and you say, the mind starts to like, you don't have just one.
Right.
It's going to be different this time. You deserve this. You put 3 days together of not drinking. So naturally, like, if you have this one beer, you're going to drink it and everything's going to be fine.
Right.
I have that one beer and I am in handcuffs.
Right.
Within 12 hours.
Right. Well, and that's kind of the power of the brain, right? Like we know that the drive chemical is dopamine. A lot of people talk about dopamine as the pleasure chemical. It's not. It's actually the drive chemical. The dopamine, the chemical that causes us to feel pleasure is endorphins. And endorphins chemically are opioids. So opioids are what give us all pleasure. It's what gives my children pleasure. I don't think they've been exposed to opioids before, but right. It is the thing that gives pleasure is endorphins in our brain. But that dopamine, that drive to use, comes from kind of this area of the brain that we is a earlier, more primitive area of the brain that we actually sometimes refer to it in medicine as the reptilian brain, and there's not like logic there, right? And so it sends that message forward to the frontal cortex, which is our CEO. It's our executive functioning is what we call it. And so it is the stop mechanism. But we all know that sometimes stopping doing something or changing a behavior is really hard. And when we have substance use involved in that, that dopamine signal is much stronger than it is in other spaces. So if we look at kind of having the best meal of your life or the best sex of your life, that pales into comparison to the amount of dopamine that is released with heroin, with methamphetamine. We've done the studies to know that. So the drive is remarkable. And so we don't always have the brain capacity to turn that stop mechanism on. And then we think about the fact that that executive area of the brain isn't fully developed until we're in our late 20s. And so if your brain is first exposed when you're an adolescent or a young child, look, one of the questions I ask my patients is, what's the first memory you have of using any type of substance, whether that's nicotine, alcohol, cannabis? Those are the big three that usually are given to young children. And it's not uncommon for me to hear ages like 4, 5, 6 years old. And, some family member thought it was funny to watch this child at a party get drunk.
Right.
Is dopamine, first of all, I'm thinking of a memory. The first cigarette I ever smoked, I don't smoke cigarettes now. I was 8 years old, and I stole it from my uncle. And I remember that my older cousin helped me plan to steal it. And this was like it was the whole like chase. It was the plan, of executing this thing that was just as driving me as getting the cigarette. I mean, because when I smoked the cigarette, it was disgusting. But going back to dopamine as drive, would you say that is dopamine the response from the drive, or is it the drive itself? Because I'm just thinking about, and you can discuss this, like, the rat park studies, which you've spoken a lot about, and you can tell us what they are, how things changed when the social environment changed. And so is there this thing where a lot of people may be predisposed because of a certain brain chemistry to abuse or addiction, if not for their life sort of taking them into different social settings that allowed them to just use that drive or that susceptibility in a more healthier way? Because you are a very passionate, obviously addiction runs in your family. It seems like it's such a faint line about what's the difference,
Right. Well, and I think we see a lot of people with this predisposition to addiction, and we see it in recovery a lot too, where we are people that tend to extremes. We are people who don't always do things in moderation. I'm going to call you out for something that I've also done, but not to the extent you have, which is run marathons.
Oh, wow.
I'm going to let you answer his question, but I'm sitting here and I was going to be very honest about my relationship to running, which I have to keep an eye on, because there is no doubt there are mornings when I wake up and I don't want to do life. I don't want to get out of bed. I don't want to see people. In fact, I can't do any of those things until I go for my run and I get that high. And then I'm able to walk into this office and see Jay and Sarah and smile, and I'm a better worker. It's all the lies I told myself when I was using opioids. It's like for many years I would say I have to get these pills because they make me a better employee, right? And so now it's almost like I have to go for this run, and we see it in the recovery community. And I'm curious what you're going to tell me, and I'm scared what you're going to tell me. But it's also, I've seen people become addicted to running and then they get injured, and those stories don't always end well.
Right. Well, we have to keep an eye on anything that we tend to extremes. And I think that's part of the addiction susceptible brain.
Bring it on. Tell
me.
me.
So I know that when I have a glass of alcohol, I like it too much. So to Jay's point, why did I go in one direction and not the other direction? I tell people I just had a really healthy fear. So when all my friends in undergrad were going to parties, I was going to the law library and studying. I graduated undergrad in 5 semesters, not because I'm the smartest kid in the classroom, but because I was like, ooh, if I go to that frat party, it's going to be dangerous for me. If I go to that thing or do that thing where there are substances, I know my brain just likes it too much. And I had seen enough in my family of people, to your point, using unhealthily with substance use disorders to kind of want to be a little bit more cautious. I don't know why I was the lucky one, right? I tell people all the time, it's not like I was raised in the house and my brother was raised in the garage. We were raised in the same home. It just, we had different experiences and that led us to different situations and, you know, one different step in a different direction and I would have been my brother and he would have been me. I firmly believe that. I don't know that I have like scientific proof of that, but when we look at the rat park studies, these were a series of experiments done in the 80s out in Vancouver by a gentleman named Dr. Bruce Alexander. And essentially what he did was he took rats and he put them in cages and he gave them the choice between water that was adulterated with cocaine and water that was unadulterated, just plain water versus water with cocaine in it. And the rats used the water with cocaine in it obsessively until they overdosed and died, essentially. And then he said, well, one of the reasons that we use rats as kind of an analog for humans in studies is because rats are social creatures the way that humans are social creatures. So he put them in a cardboard box that ended up being labeled Rat Park. And Rat Park had all the things a rat could want. Fluff to make bedding with, tubes to run in, other rats to play with, all the cheese a rat could desire, other rats to make families with. And he gave them the choice between cocaine, adulterated water, and regular water. And some of the rats used the cocaine water, but a lot of the rats, most of the rats, tried the cocaine water and then preferentially went to the plain water. So what was different? The rat social connection. So then he took it one step further and he took rats and he got them in isolation and he kind of produced a substance use disorder in the rat. So he kept them in isolation until they were using that cocaine regularly. And then he took those rats and he put them in Rat Park with some rats that had been raised in Rat Park. And what he found was that the majority of the rats recovered. The majority of the rats went from the cocaine adulterated water to the regular water. There were still some rats that had severe persistent substance use disorders, right? But the majority of the rats recovered, which is crazy. And so people say, well, those are rats, that's not humans, right? And the human analog that I usually bring up is that during the Vietnam War, about 50% of all the soldiers used heroin in Vietnam. And when they came back, and to this day, the VA is the largest single provider of substance use disorder services in the United States. We thought there was going to be this huge epidemic, and so the VA was kind of gearing up to address this, right? And what they ended up finding out was that most of the people, when they came out of war, right, which is kind of isolating, fear for your life every day, that 95% of them just stopped using because they got back into a safe, healthy community, right? For the most part. And so what is the analog of, what's the human analog of Rat Park? And I mean, we could go down the social media isolation images that, we're serving up our young children. Yeah. And I'm sure we all have strong feelings there as well. I mean, you can apparently at age 13, you are competent to make a decision about whether or not you can join social media, which is not founded in any type of reality. That legislature originally said 16, and then it was reduced for no real great reason. But I digress. But so when we look at these kind of situations, how do we create kind of the human analog of Rat Park where there's human connection and social connection, and how do we do that in a safe, healthy way, especially for those of us that kind of tend to those extremes, right? So how do you make sure that your running stays in the healthy range and doesn't run into the unhealthy range? Because there's a line there where, you mentioned injuries, but there's also just that general experience of, is this taking up more time than it should? Are you doing it to the detriment of other relationships? I mean, we could pull out the substance use disorder diagnostic criteria.
I'm bodily and mentally different than a lot of my brothers and sisters. That is a fact I know about my existence, and it's running, and it's food, and it's nicotine, and it could be gambling or sex. Thankfully, I haven't tapped into, but like I know that, and I'm very, very, very aware of it. And I oftentimes have this conversation with myself, like, oh, I'm leaving a dinner party at 9:30, guys, because I have a big workout in the morning. Like I have to go do my big workout in the morning. And like the truth is like I'm obsessing over like I need 8 hours of sleep. I need time to get up. I need to fuel properly. I need to so I can go do this run. Because if I don't do this run, then I'm not going to feel good and I'm going to have a bad weekend.
Right.
And that sounds very similar to something else I know.
Doesn't it?
Yeah.
Yeah, exactly that.
So I want to dig in because we're talking about a lot of things. I want to hear a little bit more about the work you're doing with pregnant women because I think it's very powerful. Before we do that, one of the things that I really try to make this podcast about is hope and solution. And hearing you talk about Rat Park and community, when a patient comes under your care or someone presents with if you could tell them one thing, is it to go find community above all else, or what is your starting point?
I take a medication first approach when it comes to opioid use disorder because what the data shows is that offering somebody methadone or buprenorphine reduces the outcome of death by 50%. And none of the other treatments have the ability to reduce the outcome of death like that. So that is square one. And really what that does to me is it stabilizes the brain structures so that it doesn't necessarily eliminate, but it reduces the cravings. It reduces their kind of feeling of dysphoria. Again, it doesn't eliminate kind of that having the blahs or the icks, but what it does eliminate is the withdrawal. It does eliminate that kind of drive and need to continue to get substances. And that's where I tell people is where the work really begins. And then it is kind of the idea of community and recovery. What does that mean for somebody, right? Do I talk to my patients about AA, NA, Smart Recovery, Dharma Recovery, all the community-based support groups that are available? Do I talk to my patients about individualized counseling, intensive outpatient programming where they go for counseling for 3 or 4 hours, 3 to 5 times a week, right? Do I offer all of the things? And then I tell people like, I know the math, data, and science. I can tell you what I recommend. But if that's not going to actually work in your life, then I might as well talk to my shoe because it's not going to help you. So what we need to do is we need to partner together to figure out what does that recovery program look like for you. And we both need to understand that what we think today, what you tell me today, might not be what's working in 3 months from now. 3 days from now. So it may be fluid, but it is about kind of building up that community around them.
What was the quote you gave me about emotion and passion?
Keep the passion, control the emotion.
Yeah, I mean that's where for me it gets hard because I have had my own personal experience getting well, and when I see someone, like you said, who's either it really doesn't fit into their life or they just don't want it to fit into their life or whatever their reasoning is, the emotions come out at some point if we're 6, 12, 18 months into it and it's just the same thing over and over. And that's where they probably need even more compassion and empathy and love to really be seen and heard. And that's what makes working in behavioral healthcare so hard. That emotion comes from a place of just, I'm scared.
Right.
I'm scared that something's going to happen to you.
And I say those words to a patient, right? Like, we've been working together, I'm concerned about you, and part of that fear is, right, in this disease space, we're also worried that we're going to wake up one day, they're going to miss an appointment. And what's one of the places I search for my patients? Obituaries. Mm-hmm. That's the reality of this disease space. And, I think that's one of the things that is really drawing to me for doing work with pregnant and parenting people is there is that drive to change their healthcare because of that pregnancy. And it was really kind of an accident of coincidence that led me to Pregnant and Parenting People, which is that at the time there were 3 of us addiction specialty physicians at the organization. And one was an addiction psychiatrist, so he was taking care of all of the patients that had more significant mental illness that was outside of kind of my wheelhouse as a internal medicine physician. And then we had another physician who's an infectious disease doctor in addiction medicine. So he was treating the patients that had consequences like hepatitis C or HIV alongside their substance use disorder. And we were getting pregnant people, and it was kind of like, well, you're the only female. You're the only one of us that's been pregnant before. So I guess you should do the pregnant people. And then the other thing that was really hard for me at that time, it was just a couple years after my brother had died. And it was just, I had kind of this feeling of I wanted to save people that reminded me of my brother. So seeing somebody in their 20s who was male, which is a large portion of our population, was really hard for me. And I started to question my ability to make good clinical decisions because I had a little bit of, I wanted to save them because my brother wasn't saved, so to speak, baggage that was coming with me into those exam rooms. And so I started focusing on pregnant people because it was kind of a safe space for me where I was able to make safe clinical decisions.
Yeah, I went to a treatment program. So I went to TRU too. So in 2010, I went to a place called Seabrook House, and they actually had a unit at the time. I think they for women either with children or pregnant women could come in. You shared this stat that 10% of pregnant women are using some type of illicit substance, and that excludes alcohol. And then the next line kind of in our notes here were that detoxes will oftentimes not treat pregnant women, which to me is bizarre. What is the reason for that? Are they scared that something might happen? They're not capable of it. They don't have the team to do it. What how would you?
I think it's that they're scared that something might happen. And there's
But isn't that what we do? Like, aren't we scared? Like, isn't that like the risk I have here at release? Like, something could happen, at any moment.
right.
I mean, I employ people in recovery. We house people in recovery. We treat people in recovery.
Something could happen at any moment. I think with pregnant people, you know, we kind of talk about you have 2 patients. You have the pregnancy and you have the person, right, that is holding the pregnancy. And that I think sometimes scares people. There was also some old information that's again been debunked, that detox during pregnancy posed a risk to the pregnancy of miscarriage from like the 70s. It's not actually true, just to be very clear. But we still kind of see that just general fear. There are still places where you have to hospitalize somebody in order to get them on medication while they're pregnant. Again, because of this unfounded fear, but it's just still there.
Is Suboxone and methadone safe to use while someone's pregnant?
Suboxone and methadone are both not only safe to use while somebody's pregnant, but have better outcomes than not being on medication. And when we think about it, we all know here on this podcast that when somebody is actively using substances, right, they're going in and out of withdrawal every day. Right. Likely multiple times in a single day. So to get somebody onto Suboxone, they often need to have an amount of withdrawal because the way the Suboxone works, in order to feel better when you give them the Suboxone instead of feeling worse.
I felt the other side of that. I don't wish it on my worst enemy.
It's horrible. So we can safely do that because they're doing it every day, right? And we know that they're not miscarrying in large numbers. I think one of the other barriers that's not always talked about is the fear of child protective services. In some states, not where I am, which I'm very fortunate that Michigan is not a state where we have mandated reporting during pregnancy, but in some states there can be mandated reporting to child protective services, and it can even in some areas be considered a crime to use while pregnant that can result in incarceration.
Do most of these patients, I mean, I think I read something about you've seen kind of like 100 cases from start to completion. There's been healthy births. Would you say that most of these women are coming to you and are already living with a substance use disorder? Do some of them get pregnant in recovery and then kind of relapse, or what is kind of the makeup of these folks that are coming?
And how do they even come to you? How do they even know about you? And let's just go. It's a Great Moms program, right?
Yes.
Is there anything else, any other program like this in Michigan or anywhere else?
There's a program similar to this at the University of Michigan in Ann Arbor, and then there are some pockets of folks that, there's an OB up in Traverse City, which is kind of in the northwest part of the Lower Peninsula of Michigan, where there's an OB who's boarded in addiction and kind of does a side of addiction, but more OB-GYN than addiction. So she takes care of some of these folks. And we sort of, I think in most communities, it's like this. We kind of know where the other people are. So if I have somebody that's coming and they would be closer to Traverse City, I might say to them, hey, there's another doc. If I have somebody who's coming up from Kalamazoo, which is an hour away, I might say, hey, there's another doc down there. So we kind of have like our own internal network that we kind of share across. And those are the friends that I call, the colleagues that I call if I'm not sure where to go with a patient, right? I have a colleague at University of Michigan who's a psychiatrist. And so when I have somebody and I'm not sure where to go with psych medications, I might call her up and say, hey, Maria, Dr. Music, can I, pick your brain on this patient? And so, I think because of the space we're in, we're all just like, there is plenty of work to get around. How can we figure out what the right place is for a patient? And I think we're relatively lucky in Michigan that there's a grouping of us and we're all collegial. We're all friends with each other, and I can feel like I can call them up at 8:00 at night and run a patient versus, having to schedule a time, so to speak. I don't know that all states have that sort of network within the systems.
Yeah.
But I think that that's really powerful because sometimes we all need to phone a friend, right? When I talk to my trainees, I always tell them the most important thing for you to learn, is what the boundaries of your knowledge are, so you know when to phone a friend. Because whether you're an epidemiologist or you're a physician, you need to make sure that the information that you're putting out there is accurate and complete. So if you don't know where your knowledge ends, you could cause harm. Mm-hmm. And so that's, developing those inside networks around individuals is really important so that we can make sure we're taking the best possible care of the people that we serve.
So Zach was the question, what's the profile? What typically, is the kind of person that comes to you for help?
We pretty much see it all. We see people who are actively using. We see people who have been in recovery for 10 years. We see people who have been in recovery and then return to using either before or during their pregnancy. We see people that come in and they just got that pregnancy test and they're, 8 weeks pregnant. And we see people who come in at, 34, 36 weeks pregnant because they were scared to come for prenatal care in the past. We see people that come to the hospital and the first prenatal care is at their delivery. So we kind of see it all.
You offer dual care. You offer prenatal care and natal, through and the drug treatment as well.
Yeah, yes. So we offer kind of the general OB care, and then we also offer the addiction care. So we work as a collaborative team to make sure that people get that care, and we do it in one location in one place because that way they can come and get all their care at once. What we found when we first decided to create this clinic was that we were being very healthcare centric, which probably comes as no surprise. And what we found was that we could be asking a pregnant person to do as many as 4 different things in a week. And that's practically impossible for anyone to do. So we brought all the players to the table and figured out where was the most logical place to house a clinic that would be able to provide as many of these services as possible in one location all at once for that patient. Sometimes we tell them, when they have their anatomy ultrasound, which tends to take about an hour, you may be here for a couple hours. We've got snacks. You can bring your own snacks, right? Because you might be here for 2 or 3 hours. But then you don't have to come 2 or 3 times for an appointment. Look, I saw my doctor yesterday, and I from when I got to the office till I left the office, it was over an hour, right? I mean, that's just what happens. And that doesn't even include the transit time to get there, because there's, wait times in healthcare, and it's not probably the most efficient system we could have. But how could we increase the efficiency from that patient's perspective? And that's kind of how we looked at it, and how we've been able to kind of keep the focus on what is going to support our patients the most. And we have a remarkable recovery coach, and he connects with the patient, talks to the patients, helps them make sure they have transportation to get to the clinic, helps support them in exploring things like WIC, women, infants, and children, so other social supports as well, helps them get connected to other services, ensures that if something comes up and they can't get to the clinic, that they don't lapse on their medications, right? Because these are life-sustaining medications that we're prescribing. And so it takes that whole team to come around that individual and that family unit. And so we do take care of them from pregnancy. We've had an occasional kind of, I'm thinking about getting pregnant and I'm in recovery person that comes in for kind of a pre-pregnancy session, which is fantastic. But those don't happen super often. Pregnancy, postpartum, generally speaking, in the OBGYN world, people tend to come between around 12 weeks to see the OB for the first time, by the time they figure out that they're pregnant and all that kind of stuff. And then they keep them through 6 weeks postpartum, but we keep our patients at least for a year. And some patients at 6 weeks are like, I have my physician that I had been seeing before you guys, I saw them for 8 years, peace out. And some of them, we're kind of navigating when is the right time for them to transition. Because as a person who's had children, that first year is really hard. And you're not getting sleep, and you're not getting the self-care that maybe you should, because you've got a little human and they have their own needs, and they're not really rational beings yet, right? So
yeah, I mean, women in general are underserved in this world. I mean, I always share, like, when I visit treatment programs across this country, it's 4 or 5 guys to every 1 girl on those campuses. For whatever reason, women just don't get access to treatment, or don't show up in treatment as frequently as men do. And I'm sitting here listening to you, and I can't help but think about stigma, and think about the person who might say, like, well, you have a child in your stomach. That's not enough for you to stop, doing drugs. And, like, I actually get that. Like, there's nothing that is going to, like, when I want to get high, there's nothing that's going to stop me. It doesn't matter if my parents are in the room with me. It doesn't matter if I'm carrying a child. It really doesn't matter. And that's where the compassion and the kindness and the work that you're doing just becomes so important, because that person, trust me, feels bad enough.
Oh my gosh, I can't tell you the number of times I've said to a patient, like, who's had a relapse, or has been using an episodic use, or is not currently engaged in kind of a recovery program and is actively using, how many times I've said to them, so have you beaten yourself up enough about that? And the answer is always yes. And then the question I always ask is there anything I could say that would make you feel worse? And the answer is always no. So I don't need to beat you up. Let's talk about how we're going to move forward together. And I always tell people, if somebody is still using an active disease, but they're showing up to see the addiction physician, there's some part of them that wants something different, or they wouldn't be coming in for that appointment. And so my job then becomes to support them and help them figure out what is that driving force. What are the things that are barriers in their life to what their goals are. And their goals might not be freedom from substance use disease, right? Like, their goals might be to use safer, right? And so I'm going to have that conversation with that patient to try to keep them safe, make sure they have access to harm reduction services, make sure they know where to go in our community for those services, hand them a box of naloxone if I need to, if they don't have that, right? Like, what are the things that we can do to support them here and now, just so that we can establish that trust? Because maybe one day they'll wake up and they'll have a different thought. And if I have alienated them by saying something like, well, why didn't you just stop? Don't you know you're pregnant? Well, yeah, they do. And for whatever reason, they're not in a place where it's feasible for them to stop.
What's the demographic? Is there a typical demographic of woman that comes to the clinic?
Not really. I mean, addiction doesn't have boundaries, right? I've seen people who have come to me from affluent areas of our community, from not so affluent areas of our community, on commercial insurance, on Medicaid, all different skin tones, all different educational backgrounds. Our biggest referral source, which I'm really proud of, is not from other healthcare providers. It's word of mouth, which I think, hopefully to me at least, means that we've established trust within our community, that former patients of mine will say to their friend, hey, you should go see Dr. Poland.
Right.
And I think that that's really cool.
It's incredible. It's incredible. And the work you're doing. What is next for you? Where is this all going in the world of Dr. Cara Poland?
Yeah. Can you talk about like what you're doing on the, trying to do at the national level, and then also like, not to get political, but just to talk about how your work is being impacted by, what, some decisions being made.
Yeah, so from a national standpoint, we're really pushing for access to medications. So right now there are conversations. It was being worked on in the last Congress, but modernizing opioid Treatment and Accountability Act, or MOTA, which would allow addiction specialty physicians to prescribe methadone. So giving access to medications to all individuals, right? Methadone clinics were created in the 1950s when it was predominantly heroin in large cities, and it was actually created and marketed on a probation or parole type of model. So asking people to come in every day to get dosed 6 or 7 days a week, really kind of punitive in terms of how they addressed substance use. And those regulations were relatively recently changed in the last couple of years to make it a little bit less punitive, but it's still, access is a huge issue for methadone across the nation. So that is a really big push, is to try to make methadone more accessible by allowing physicians who are boarded in addiction, either addiction medicine or addiction psychiatry, to prescribe it from their office the same way we prescribe buprenorphine, the same way we prescribe any other controlled substance. So that is kind of a really big push, because again, if we can provide people with an opioid use disorder medication, we reduce the outcome of death by 50%, which is, if there was something that reduced, left small toe amputation and diabetes by 50%, everybody with diabetes would be offered that medication, right? And so we need to do the same in the world of addiction. That's a really, really big push. Pay parity is a huge concern. The proportion of people with a substance use disorder that are underinsured or insured by public insurance like Medicaid is higher than in other disease spaces. And we know that generally speaking pays less. So we are trying to engage in conversations around parity for payment. That would be really changing in terms of kind of this idea that, behavioral health is sometimes shoved in the oldest building in the corner with the mildewy carpet, which is very common, right? We want to create open, welcoming spaces, right? There's a big Heart Institute in Grand Rapids that's like 10 stories, and it's got this beautiful silver building, and we've got like an old converted
shack in the back.
Right. That's kind of what it is, right? But it's, so how can we elevate those types of images across the nation is a big part.
Kind of fake it till you make it with that stuff. For me,
right.
Like, why not put these people in a really nice environment so that they can actually see and feel like what life is available to them?
Right. So that was part of why we put the Great Mounds Clinic initially in the maternal fetal medicine office, because it was like bright and shiny, and there's ultrasound machines right there in the suite, right? Like there were all these like little perks that we could give our patients because we were in this fancier building, right? Downstairs was a Qdoba and a Starbucks, right? And so they could come and get their Starbucks, on their way up, right? Like it made it feel a little different than it does in other spaces. That's always, a fun thing to be able to have, or to offer patient a voucher for Starbucks if we're running behind, so just again, being respectful of them as individuals. But how do we do that on a national scale and build that infrastructure is something that I'm really passionate about and think about in terms of Congress. Look, there is no boundary to addiction. Addiction affects everyone. It doesn't matter what your political party is. It doesn't matter who your family is. Addiction can be a part of your life story. We know that 1 in 7 people in the United States has a substance use disorder if we take out nicotine. So just think about that. If we include nicotine, it becomes 1 in 4. So it's amazing the number of people that are affected by it. So we can't go anywhere without seeing people affected by a substance use disorder. So how do we create that rat park on a national level? The American Society of Addiction Medicine, just last month, we came out with a public policy statement on housing for people with a substance use disorder. What business does a healthcare group of physicians sitting around a table have talking about housing?
I've been in housing my whole career, and it's we are high end, highly structured, so a certain population can afford our services. I'm happy to show you one of the properties upstairs when we're done here. And people always ask me why it's so expensive. Well, it is expensive, and part of that reason is like to really do housing right, like to really do it right. It's expensive to have the staff, to have the support, to have the people there to help monitor some of the medications and the drug testing and the things that go into really running a safe home.
Right.
Probably isn't going to be $300 a month.
No, it's not. And
insurance doesn't.
Insurance
will
doesn't
not
cover
recognize it as a. So that's my soapbox.
No, we can. I might shove you over on that soapbox to climb up with you. Cool. I often tell people that my soapbox just got so high that I'm going to have to be careful climbing off of it because I might break my femur. So it's right. Like, but these are the conversations that need to be had. And look, no one person, no one party gets to own the rights to addiction, right? Because it affects everyone. And when we look at the way addiction has historically been funded, which is some of what this current administration is looking at doing more broadly, it's by something called block grants. And the problem with funding things through block grants is anytime there's a grant, it's time limited. So every time I get a grant to provide a service to my patients, I have to be thinking ahead 2 or 3 years to how am I going to sustain that service? And if I don't get additional funding to sustain it, then that service falls away, right? My recovery coach is currently funded by a grant, and it is in the back of my head, like, how do I care for this population? How do I continue to provide that like feeling of safety and somebody who's relatable on a very different level than I am with my, starched white coat that I don't wear, by the way, but you know what I'm trying to say. Compare, and the power differential, because I always hold the power of the prescription, right? And for somebody who's on Suboxone and it's a life-sustaining medication, they're always going to be wondering, if they say something wrong, might I stop that prescription? No matter how much I try to reassure them that, no, I'm not going to. It's always going to be there because I'm in that position of power in that situation, right? So how do we work across the aisle? Right now, some of my programs, very frankly, are in threat, right? And a lot of my work is workforce education that is funded through like NIH grants and SAMHSA grants, but I haven't been able to hire a program manager for one of my grants because I have to get approval from SAMHSA on their CV, and this person's been waiting since October to start a job. I can't continue to ask him to wait for somebody to check a box, and this is a guy who has his master's in public health and has worked for 8 years in workforce development in substance use disorders. He's overqualified for the job. He just wants to work with me, and so that's why he's waiting for this job. He could
I want to work with you too. Next will be my grant. I want to ask one last question here, and it's I could talk to you all day, and I'm sure Jay's got a laundry list of things that he's wanting to ask, but the clock is running, unfortunately. So, you've talked a lot about the value in Suboxone and methadone and the 50% reduction in death. There is a large conglomerate of folks who I have compassion for, because I can't expect them to have my experience working in behavioral health care. They're not a trained physician. They just don't know. But they will turn to that person and say, well, you're not in recovery if you're taking Suboxone, or you're not in recovery if you're taking methadone. And they probably don't understand how much damage they're doing with those words to the person who is trying. How do you navigate those conversations with that person? Because it's something we see, and it's hard.
I try to empower my patients to know why they're on the medication. And so I usually tell people that what we're doing with the medications is stabilizing your brain so that you can do the hard work that is recovery. So what we're trying to do is we're supporting you in that space. And we know with something like major depression disorder, when somebody has a first episode of depression, we don't want to start medication for less than 1 year. At 1 year, we might talk to them about possibly tapering that medication. Do they need it around the clock every day, 365 days a year? Or was that an episode of depression that was isolated? But once somebody has 2 or 3 major depressive episodes, then we know that that person's brain just needs to be on that medication because their brain needs it for that physical support. We also know that if somebody has high blood pressure and we start them on medication, we also talk to them about a low salt diet, about, maybe losing some weight if they are overweight. And if they come back and they see their primary care doctor and they've lost 100 pounds, and now they come in and they say, sometimes when I get out of bed, I feel a little dizzy and lightheaded. We check their blood pressure laying down and sitting up. And if we find out that their blood pressure is going down when they sit up, or they're having these dizzy episodes, we don't tell them on your way home, go grab a box of Oreos. You should probably gain some of that weight back. We adjust their medications.
Yeah.
And we should be doing that in addiction. And everybody's brain is a little different. And some people, I think, and this is just a Dr. Poland hypothesis, that some people, part of what drives them to substance use is that their brain is natural opioid deficient. Just like some people who kind of edge toward depression, they go on a medication called selective serotonin reuptake inhibitors. And what that does is it increases the amount of serotonin available to the brain. So are there maybe some people who are endogenous, naturally occurring opioid deficient that need the Suboxone, need the methadone to support their brain so that they can live life on life's terms and do it in a way that is safe and feels good for them? Absolutely. And who am I to judge if you are struggling with weight loss and that's part of why you have hypertension, any more than I am to judge somebody with a substance use disorder who's taking medication. So I try to empower my patients to kind of be able to have a version of that conversation with other folks so that they can put it into terms that maybe that person can understand from their own personal experience. Because if we can ground it in their personal experience, then it's easier for them to understand how that might look and feel for somebody with a substance use disorder.
No, I love Dr. Poland.
This was really good. I appreciate you. Jay should deserve some credit here because he was the one that was stalking you, and we have to talk to her because the work she's doing is so incredible. So kudos to Jay. Thank you for.
I'm glad we got you here. Thank you. Yeah.
And we'll have to connect offline on some of this stuff.
You guys are going to have to thank Miss Madison because
Right,
with all due respect, I had no idea who you were.
That's fine.
I didn't even know what The Bachelor was.
That's good.
Wow.
And she was
you.
like, no, this is legit. Because I was like, I don't know, is this legit? I showed her the email and I was like, from Jay, and I was like, is this legit, or do you think this is some sort of weird spammy thing? And she's like, no, this is real. I know who he is.
Thank you, Madison.
So, there we go.
I appreciate you, Madison, and that's a whole nother episode. The
The collateral benefits of reality TV.
It's been a wild ride, and I'm here having conversations that I want to be having, and that's most important. So,
Thank you.
That's it. Thank you.